Good morning, everyone. Today we're going to talk about vaccine issues, and I would like to dedicate this presentation to Pam Russell for her immense contributions to this club, to this Rotary Club, to Rotary International, and for being a friend to all of us. Thank you so much, Pam. I'm going to go rapidly through this, so you already all know me. And we're going to be talking about some issues with the vaccines. And the first issue is when? When are we going to get the vaccines? And it has depended greatly on the FDA, and they're making progress towards authorizing a couple of the vaccines already. Pfizer, BioNTech, and Moderna vaccines are authorized and are being used. The Pfizer and Moderna vaccines completed their clinical trials around November and got authorized shortly thereafter. The next one to be authorized, we expect, will be the Janssen vaccine, Johnson & Johnson Janssen vaccine that has been submitted. It will be taken to the advisory committee, to the FDA's advisory committee on the 26th. And it's expected that in the course of a few days afterwards, it will be authorized and will be out there getting used. AstraZeneca has completed accession on their clinical trials in the US, and they're expected to submit their data to the FDA by the next 2 or 3 months. And next will be Novavax and others coming along. Next issue is which vaccine is best? Everyone is asking, should I get the Moderna? Should I get the Pfizer? And the short answer is don't even look at this slide because you will find that they're almost identical in every one of these measures. So what we can say is that today there is no clinical reason to consider them different. So which vaccine is best? The one that you get is the best. So go get your vaccine. Another issue, allergic reactions. And what we have found for Pfizer in the first 10 days, about 2 million doses administered, allergic reactions, about 11 cases per million. Moderna in the first 20 days of use, about 10 cases, and that amounts to 2.5 cases per million doses. So the bottom line here is severe life-threatening allergic reactions are very rare in occurrence, and you can almost predict who's going to have them. People who use EpiPens for any other allergies have to be very careful. They should receive their injection, but it should be done in a controlled situation, in a clinic or a hospital setting, where epinephrine and other medications are available should they need to be treated for an allergic reaction. Otherwise, the recommendation is do get the vaccine unless you are known to have allergy to any component of the vaccine, particularly PEG. And if you do have a known allergy to PEG, you should get a skin test. And if it's positive, then you should probably not get the vaccine because one of the components is PEG. Otherwise, get the vaccine. Very few people have this. Another issue, antibodies. You get the vaccine and what happens? You develop antibodies. Your immunologic system recognizes the components of the vaccine, reacts against those components, and develops antibodies which would then attack the virus should you get the virus. So these antibodies are your defense against future infection. They amount to protection. They protect you from the virus. And the antibodies are nothing other than a reaction to certain components of the virus itself, which the vaccine takes to your system. And mainly, it's the spike protein. Now, people want to know, has the vaccine been effective? How do you know that? Well, you get a blood test and you're tested for antibodies. And the current tests will determine whether you have antibodies to the nucleocapsid protein, which is this part of the covering of the RNA within the virus, or to the spike protein, which is this spike on the outside of the virus itself. Now, if you have had the disease, if you have had COVID-19, you will test positive for anti-spike protein antibodies, and you will also test positive for anti-nucleocapsid antibodies. If you have had the vaccine, not the disease, but the vaccine, then you will develop only anti-spike protein antibodies, because that's what the vaccine develops. The vaccine has your immune system develop anti-spike protein antibodies, because that's what the vaccine delivers, the spike, and then your body reacts against that spike. Thus, what tests are out there and available that you can take to determine whether you have reacted well to the vaccine? Abbott has a couple of tests seen here on the slide. One of them is for anti-spike antibodies, and the other one is for nucleocapsid antibodies. If you have had the disease, you will test positive because the nucleocapsid and the anti-spike antibodies will be present. But if you have had the vaccine, you will not have nucleocapsid antibodies. And if you get these tests that do not test for spike, you will be negative. So one has to make sure, if you want to know if you have developed antibodies to the vaccine, you need to get a test that tests for spike antibodies. Otherwise, you will test negative. I'm sure that's clear as mud, but we can take some questions perhaps afterwards. The other big issue with vaccines is the variants. And if you stretch out an RNA and you can show it as a band, the RNA goes from here to here, there is one section of the RNA that is important in that it transmits the code so that a spike protein is generated. Only this part of the RNA does that. The entire RNA has about 30,000 base pairs. So there are just a few of those base pairs in that section. And mutations can occur all along. I tried to show 30,000 base pairs, but this is how many I could show. Maybe leave it's 30,000, okay? And that's where the spike protein information is shown, is encoded, and mutations can occur, changes in the base pairs can occur just about anywhere along the length of the RNA. And if they occur in these parts here, they are mostly not important. They're mostly unimportant. But if they occur here, where the spike protein information is coded, then they can be important because they can affect the activity of the vaccine. Taken together, all of those make up what we call a variant. So there are many mutations put together. We call that a variant. And the variants of concern, and they're being called VOC nowadays, are mostly the three shown on this slide. The one that has come up in the UK, the one in South Africa, it's called B.1.351, and P1 in Brazil. Never mind the numbers. There are many more cases now in the US. This slide is out of date from the CDC. It's about 2 weeks old. And in fact, we now know as of this week that we do have this South African variant right here in California. There's been a number of cases reported. So the variants travel fast. Now, it's important to know that the UK variant has 8 spike mutations, whereas the South African variant has 10. So it has a higher likelihood of affecting how we respond to the vaccine. Future variants are probably going to have greater transmissibility. They will probably not be deadlier. The vaccines may not be effective. We don't know for sure as yet. Certainly Moderna has shown in the laboratory that their vaccine continues to be effective even against the variants. So that is very good news. Current antivirals will probably not be active, but we are in the process of producing antivirals that will be active against these variants. And the good news is that already the pharmaceutical companies like Pfizer and Moderna and others are working on booster shots that we can get perhaps 6 months to a year after we've had our vaccine, and that will confer further protection against these variants. Another piece of good news is that new vaccines are also on the way. They're being produced and will be available in the near future, and that the work towards better and more effective antivirals continues. So this is the good news. We're going to be okay. In the meantime, go get the vaccine. It's very important. Get immunized. I'm getting mine today, in fact, the second one, and you should do likewise. Thank you for your attention.